Good afternoon, everybody. Welcome to this September meeting of Derby's Health and Wellbeing Board. Thank you for coming. I have one apology myself, which is Carmel Ashby, Councillor Carmel Ashby. Do we have any others?
Yes, we do. Councillor Aldred, Emma Aldred, Jim Austin, who's covered by Lucy Allen, Paul Brookhouse, Robin Jewis, covered by Alison Wynne, Catherine McLean, Jane Needham, Mark Powell, Andy Smith, Alan Reid, Kim Harper and Coldring Willis, and that's it.
Thank you for that. There are no late items. Do we have any declarations of interest? Thank you. Are we all happy to accept the minutes of the last meeting? Yes, looks like it. Thank you. And just moving quickly on to the health and wellbeing log. We seem to have everything either in progress or complete on that. So the only thing that I'm a little confused about myself, actually, Alison, is the air quality one. We do have the report today, but we haven't got it agendaed to discuss it as such. It's attached because we didn't have the full report last time, and now it's attached as an appendix to the action log. So are we intending to perhaps look at that again in more detail at another meeting, or I know some members would probably like us to give it fuller consideration?
I take advice on that. I think we'd agreed at the last one that we'd share it as soon as it was available. So we've shared it with the this report. So happy to bring it back again if you'd like further discussion on it.
Could I just ask if any members of the board have particular views on this, please? No? Well, in that case, what I suggest is that we note the report for now, and I will, if it's all right for the board, I will think about whether we need to bring it back or not. I've had a quick glance at it, but it's quite detailed and it's quite important, and I know there are some actions that are being held up partly because of funding. So I think I'll talk to the officer responsible and think about whether it might be useful to bring it back, because it is a really important issue, and I know it's important and of interest to a lot of people in the city. Thank you.
Just before you move on, I've just got a further update in terms of the consideration of indoor or residential air quality. So colleagues are, I think, have a meeting arranged to discuss further, but in the meantime they have shared two reports, one of which is an expert group report that's been prepared on behalf of the government, and one is a Parliamentary Office of Science and Technology report specifically on those. So I'm happy to share those in advance if members think that's helpful, or else we can kind of just incorporate in the update at a future meeting.
Councillor Kerr.
Two things. I think it's very difficult to know whether it's important or not without having read it. It could be inconsequential, or it could be full of important things. But there was also a report this week that I saw about the amount of microplastics that people are breathing in, and it was particularly highlighted in people's homes and cars that this was happening. So if we're going to have a conversation along those lines, it might be to include that subject as well, as it seems to be fairly current.
Okay, I suggest, again, if you'll indulge me, I think we'll think this over. Sounds like we might need to bring it back as a more substantial item at some part, Councillor Kerr. If we have a quick look at the reports, and I'll get in touch with you outside the meeting, Councillor Kerr, and we'll have a think about that. I'm not against bringing it back as a more substantial item. It's important. Thank you. Councillor Hazelgrave.
Having looked at the kind of headlines of the report, it seems quite reassuring that generally levels are not anything to be particularly worried about. But of course, concentrations of particular pollutants could be localised, and I'm just concerned that maybe some of our schools, particularly primary schools, where our children in the same classroom for quite some time, and if air's coming in and it's contaminated, that could have an effect. And I wonder if any attention is given to that when the surveys are carried out, to ensure that we've got a reasonably healthy atmosphere around our schools and not compromised by pollutants from vehicles or local industry. You never know. Yeah, thank you.
Thank you. Well, I have spoken myself with the officer who leads on this around these issues in the past, and I do know in general terms that the general direction of travel in Derby and the situation is quite good, and that we don't exceed the government's thresholds for air quality, but we don't tend to meet the World Health Organization ones, but the government's ones we do. And they do take those factors into account. But what we need is the relevant officer here to answer those questions, Councillor Hazel-Grave. So what I would say is that for me personally, I know we've got a fairly reassuring story on air quality in Derby, except if you take areas of compliance, which at the moment we're not obliged to comply with. But I think we will ask him to come along and talk to us briefly, perhaps at a subsequent meeting. Thank you.
Thank you, Chair. Councillor Cecile Wright. Aligned to that, and I've only had a cursory glance at the actual report, perhaps we could also have information locality-wise, relating to the differences, the discrepancy for densely populated area. And I'm thinking about my ward in particular, an inner city ward that's densely populated, and the density of cars, vehicles. Yeah, quite problematic. Thank you.
Yes, thank you. I do know those factors are taken into account, but I think, as I say, I'm definitely not the expert, and we have an expert, and we'll bring him back. But we'll make a note of those, Alison, and make the officer aware of them, and we'll bring it back to another meeting. So thank you for that. So what we're going to do now, been asked if we could swap 6 and 7, items 6 and 7 round. So we'll take, first of all, the refresh of the Joint Health and Wellbeing Strategy report first, and then move on to the Place Partnership report after that. So, Siobhan Horsley, thank you.
Thank you, Chair. So today I'm just bringing an update on the Health and Wellbeing Strategy development. So this strategy is a statutory strategy which we are required to work on and update, and it kind of sets the stage for our local city level activity around health and wellbeing. So just move on the slide. So the ask of the board is to note the work that's been done so far, both within this presentation and within this position statement that was shared with the agenda, to agree to our general principles which will underpin the strategy, and support the next steps identified, which will be more of a joint workshop event to kind of explore the priorities in a bit more depth and agree those. Okay. So what I'm going to do today is just briefly provide a summary of the work that we've been doing already, highlight key themes within that and the direction that we want to take, and just to gather any input that you may have in this room around the next steps. So this work so far has been led by Public Health on behalf of the Health and Wellbeing Board, with collaboration from Derby City Place Board and Derby Health Inequalities Partnership members. We formed a multi-agency working group drawn from these partners, based on, some of you may be at an event last September where we all came together, and there were some volunteers from there to kind of move this work forward on our behalf. And just to note that kind of the key partner organisations in the city have been represented on that group. So in terms of just the timeline so far. So pre-September last year, there was some kind of mapping work, looking at what other areas have done, and a bit of informal collaboration about how do we want this to look like for our city, and that agreement that it does try and sit across the key partnerships in the city. And we held a stakeholder event September 2024 when we looked at these shared priorities from the Health and Wellbeing Board, from Derby City Place Partnership and from Derby Health and Equalities Partnership, and started to explore our common ground and what was important to us as a city. We had a bit further discussion at a DHIP community event in October. And then we also had these monthly working group meetings, and there was quite a lot of background research that went on along at that time by colleagues in our team, just to kind of inform those groups and keep it going. Earlier in the summer, we developed a position statement and a plan for engagement, which includes this board. We took it to Place Partnership Board just this week as well, and also inviting members of the working group and colleagues to share this information themselves and to kind of generate that kind of overall interest and commitment to this approach. So, as I've already mentioned, we'll be looking at bringing everybody back together later in the year with a view to launching the new strategy for April 2026. That is our plan.
Sorry, Siobhan, did you say April 2026 or 25?
26. So the new strategy will be next April.
Oh, yes, thank you.
Yeah. Okay. So the first thing that we did as a group is look at what the current strategy tells us, and did a bit of a review of that. So you'll be familiar with the plan on a page, which has kind of driven a lot of the reports and updates that have come to this board over time, and connects well to the ICS priorities in terms of start well, live well, and stay well, and age well and die well. Which is one of its strengths, really, within the existing strategy, that it connected with the ICS strategy. It was based on local data and inequalities in terms of that prioritisation, and there was visibility through the Health and Wellbeing Board reporting. There were some challenges, I think, in terms of the ownership and governance, might not have been as strong as it could have been. We are aware, as everyone is aware, there's quite a lot of system plans, and perhaps there's not as much alignment across those as we would like. We felt we could have done more around progress measures and how we delivered some of the work to really understand what works, what doesn't, how are we doing, how do we know we're making a difference. And then, as ever, there's always challenges around equitable reach and co-production. So these were the things that some of the things that we really want to address in our next strategy going forward. So in terms of, we also looked around at what other areas do, how they structured their strategies, how priorities were selected and what measures were used. We did so when I say we, I mean the working group. So we did healing strategy. We felt it was quite clear, bold. It kind of said what it wanted to say, measurable outcomes, and really focused on system change to reduce inequalities. And that strategy was shaped by Marmot principles, so Professor Michael Marmot principles, which are listed on the side, but kind of addresses kind of best start in life, enabling everyone to maximise their capabilities and control over their lives, looking at fair employment and good work, ensuring healthy standards of living, creating and developing healthy, sustainable places and communities, strengthening the role and impact of ill health prevention, tackling racism, discrimination and their outcomes, and pursuing environmental sustainability and health equity together. So that's kind of, and there's a few strategies around that are underpinned by a similar set of principles. A bit more learning from ourselves within this group. So we said, well, how will this strategy be different from the last one? How will it shape decisions in the city and the investment that we make? And how do we know if anything's changing? So then we did do a bit more focused work, looking at developing our measures, understanding what our public health outcomes framework indicators were telling us, and exploring ways of building out accountability and visibility and shared ownership of the strategy. So we agreed that the strategy, probably a 3 to 5 year time frame, that's kind of up for discussion later on, would be about setting the tone, the direction and the priorities for Derby's health system. So kind of that strategic North Star, as it were, for us all to be working towards. We felt that it would frame both strategic and operational system plans, not necessarily go into tons and tons of detail as a strategy, but really set the stage for partner organisations and collaborations to think about how do we work together, or they work together to meet those overall objectives. We wanted it to enable us to work together, so as co-production, that shared ownership and accountability, and really provide a framework and help us as a city measure impact better. And in terms of getting towards what the detail might cover, or the kind of the high level content, as it were, we felt a focus on building blocks of good health were important. So building blocks, wider determinants, social determinants of health. Prevention was really important, and fair access to services. So those are kind of the three very broad areas of focus, but kind of cover the breadth that we want the strategy to look at, and therefore the work of the city. And we felt that it would be helpful to have some strong principles within there that we all can include in our work and get behind. So, and these were community-centred kind of strategy developments, that community is at the heart, informed planning, so planning informed by integrating both data and lived experience, and a real focus on building capacity and resilience, and reducing inequalities. So a little bit more detail on the principles that we know. So drawing from the evidence base, these are the things that work to put those principles into action. So including communities at the core of design and delivery, working with our community networks for engagement, co-production and empowerment, really focusing on that belonging and connection and participation to reduce inequalities. Informed planning through data and experience. So to use data, insight and lived experience to understand needs and assets of the city. So it's trying to take a strength-based approach as well. Ensuring strategies are responsive, equitable and culturally respectful, and promoting thriving communities through dignity and inclusion. And then the third principle around capacity building and reducing health inequalities. So again, working at building resilience and capacity at individual, community and city level, using a proportionate universalism approach, and really harnessing our partnerships to deliver long-term change. So we focused quite a bit of discussion on how do we measure change. You'll have heard it's like a recurring theme in this talk, and try to think about, can we just move on, sorry, Linz? Kind of just like a mental model really to help us think about this, because measures are complicated, and it's a complicated world in which we operate. So the way that we've started to characterise this, and we think it's helpful to share with colleagues, is that we have our population health indicators. So primarily we use public health outcomes framework, but it's not limited to that. There's plenty of kind of population level measures that we use to drive our work in the city. But it's very difficult when we look to measure the impact and the progress of what we're doing to use those as an indicator of progress, because often they're intergenerational or they're population-wide. So I'm thinking those outcome measures like life expectancy or healthy life expectancy and so on. It takes a long time and it's multifactorial to try and influence those. So what we kind of need to do is start to take a combination of those together to think, well, actually, what they do is indicate areas of concern, but they're not necessarily the best measure for output. So by looking at those, we can say we're really, really concerned about X, Y, Z, but it's not necessarily the best way to measure it. So I've got some examples, Linz, if you can just click forward. So examples of where Derby City is in the worst 10% of local authorities in England. So that's if you ranked all of the local authorities on any of these objectives, Derby sits there in that bottom 10% ranking, and that includes children, young people's physical activity, alcohol admissions, smoking prevalence, children in low-income families, and falls admissions. So some of them, kind of, the timeline might be a year or 2 years, but some of them, the timeline is quite long, but it tells us what's important. Other indicators with a high population impact, LINs, would include kind of children and young people's healthy weight. So we're not quite in that bottom 10% for those, although we are quite low, but it has a really high population impact, doesn't it, across the system. So we're really concerned about that. And then finally, the last green little circle, those indicators that, you know, we're not in that bottom 10%, not a massive high population impact, but there's a real inequalities and disproportionate impact. So air quality, which we've already talked about, might be one of those. So they're just kind of illustrative examples, really, and there's a bit more work behind the scenes to really understand what that long list of things that we should be worried about in this city should be. And we will come to that a bit more, so to stay with this slide for a sec. When we kind of meet together later in the year, we'll kind of bring some structured work around that. So yes, so we end up with a big priority list of things that we're bothered about, but then we also, at the same time, are thinking, well, what works to impact these things in terms of the evidence base? What works, you know, what are good progress measures at organisational level that can tell us we're doing the right thing? And how do they add up to system progress measures that tell us that we're doing the right thing? And that combination of that kind of priority list, system progress measures, are kind of what should be in, and how we address those is what should be in that health and wellbeing strategy. But obviously there's quite a lot of work in each of those things, and I think if I was going to redo this slide, I'd put insight in there somewhere as well, because I think that insight around what works and what's kind of most acceptable and accessible for our own populations is also helpful to help us know that we're doing the right things. Thank you. So just to summarise then, where we are now. So we've, as a working group and with some wider stakeholder conversations, either individually or kind of in other groups, and we've got a few more of these sorts of conversations planned as well. We've completed a review of the current strategy and identified our strengths and challenges. And we've researched best practice and the evidence base for strategic actions. And we've started that engagement and co-production process with partners. And we're starting to see clear priorities and principles emerging from all of these discussions. And the discussions are important in themselves. So that process of engagement and really understanding what's going on and understanding and listening to each other in terms of what is important and how things do work together has been really important. So these are so just to go back to where we think we're going in terms of if I was going to write an executive summary of the strategy at the minute, it would contain some of this stuff. Our 3 priorities would be building blocks of good health, prevention, and fair access to services, and we would have these principles underpinning it. So that strengths-based approach, resilience approach, using data, insight, and lived experience, focus on equity, dignity, and respect, and tackling inequalities proportionately, and really having communities and neighbourhoods at the start. And I've just put a little star next to neighbourhoods because of the changes in language that are happening at the moment across the system, and the trends in administrative language, meaning that we're kind of talking about neighbourhoods in different ways. And there's a bit issue sometimes, isn't there, around we can use the same words, but they can mean different things. And I think there's a real opportunity with the strategy work to think about the language that means something to us as a city and have that shared language, which will help a lot of our collaboration, and a shared language that means something to the population and general public as well. And then, so as I've said, next steps. At the moment, we're continuing that engagement process, updating, gathering feedback, insight, what do people think, we're going in the right direction, and then bringing everybody back together in November, December. And when I mean everybody, I mean representatives from this board, from Place Partnership Board, and from the Health Inequalities Partnership. So we've got that diversity of kind of strategic leadership as well as community participation. And then to really go into it in more depth and agree what we want to focus on. And take it from there. So the ask of the board then, just to remind you, would be to note this work and support its development, and support, yes, to agree the principles and support the next steps identified. So thank you very much.
Thank you, Siobhan. Any questions or comments? Councillor Hazelgrave?
Thanks very much for this. Some great work being done by the working group, and I particularly liked those Marmot principles. I thought they tied in very much with the kind of ethos we have at Derby City Council and all sorts of other things. And it's not something that's totally alien to us, far from it. I noticed was it from Ealing it came, which obviously is in kind of central London. I know it's on the Central Line with Ealing Broadway. That's about all I know about it. But I'm assuming that since they've adopted the Marmot principles, as quite a few other authorities have done, they've seen positive outcomes going in the right direction across all, if not most, of those measures that we're looking at in terms of decreasing health inequalities and improving the quality of life generally of people. And you know, I particularly like the focus on generations and specifically on children and young people, on healthy weight and physical activity, tying in body image and having a positive outlook about themselves, and of course mental health. But I'm a councillor for all generations in my ward, and I want really good outcomes for everyone. And of course, I suppose the answer is if we start early, we get people on the right track and having some autonomy and understanding that they have control over lots of factors that will increase their quality of life in terms of their health and their well-being. So thanks ever so much for the work, and I wish you very well.
Thank you. Councillor Kerr?
Thank you. I feel that you've had some really good discussions, and it's helped the body of your working party to actually feel they know where they're going forward, and I hope that's a true reflection of what's happening. The thing that I feel is missing from this, because it's work that matters to every bit of Derby and every organisation within Derby, and not just within, if you like, the council or the health sector. It's something which has economic implications, it has wellbeing implications, it's really broad. And the element that's not included in here, which I just wonder whether it could be, is actually the sort of employers' side of things, the business community. Because as I understand it, one of the reasons that drove the original formation of the NHS was wanting people to be healthier as employees. And that is still one of the things that we should be looking for. You know, within the council, we monitor the level of absenteeism because it matters, and it matters to every business. So they should be really keen partners within this, and because it matters to their bottom line. And I don't see them here, but they could be really positive at dealing with some of the things like smoking reduction. They could be dealing with the relationship with alcohol. They could be looking at even things like their pay regimes, so that we are reducing the poverty within families. There are things that they could be doing if they shared this vision. And I wonder if there's a partnership possibility with the business sector through the chamber or something like that. And maybe this is the point where they should be invited to the next meeting.
Yeah, thank you. I think we can have a look at that, because we do have some relationships with business, certainly, like operationally. But yeah, certainly at that strategic level, what is that role as a significant partner? And we know that work, economics, poverty, etc. is a driver of health, and it is exploring their role within that. Thank you.
Thank you. Councillor Wright. And then...
Yes, thank you for this rather comprehensive document. I'm really pleased that it is informed by the Marmot principles in terms of tackling health issues and health inequality. Inherent in the work of Professor Mormont, are issues relating to structural, systemic barriers and issues that prevents a healthy society, a healthy demographic, etc. What I don't get from the presentation is an indication of how resources, the mobilisation of resources appropriately and relatively appropriate resources is impacting on the strategy. Thank you.
Thank you. Did you want to come back now or a bit later on when you've heard other comments, Siobhan?
Whichever you prefer. So,
Come back now on that point,
Yeah,
because
yeah, I
Cecile's
think,
asking a specific point. It's a point I'd support.
yeah, and I so I'm out on, yeah, I do support that point. I think where we're up to at the moment is agreeing what direction we want to take and how we want to take it, and I think then how we align resources under that vision is what needs to come next and needs to be part of the fuller discussions. Part of the rationale, well, you know, we've developed this as a partnership, as a board, with all key partners, so that people, you know, all stakeholders there kind of signed up to the development of it and how it goes. So, you know, the idea is that kind of strategic strategy that does drive decision making and give us a point of reference for making those decisions around resourcing and everything else. Thank you.
Thanks. Sharon Buckby.
Thank you, Chair. So I'm just picking up on the point around employers. We have the Derby anchor group, Derby and Derbyshire anchor group, that is both private and public sector leaders within the city and also those working across Derbyshire. There is a good employer charter that's just being developed. Also within the East Midlands Combined Authority, there's a good employment charter being looked at from an MCA perspective. So it might be relevant to explore how those health areas that were identified previously by Councillor Kerr could be fed into that good employer charter.
Thank you. Yeah, and I don't know if you want to come in, Chris. I know that that you're not obliged, but I know that this is something you've raised. I know with me that there are similar parallel discussions happening at the City Partnership Board. But I think previous discussions I've had was this at the ICP, where we were talking about the government's good work programme. There did seem to be more urgency in actually getting employers around the table in relation to that. But did you want to come in, Chris?
Read my mind, Chair. Thank you. Sort of a track record, really. So this is one element of the partnership here in the Health and Wellbeing Board. There are other partnerships that are happening, and Sharon's absolutely right around the anchor partnership. We've got the Derby City Partnership Board itself, which connects more broadly with other agencies and colleagues. So I think well, the challenge is that the paper in front of us really support the working group work that's been done, fully support. There's just a question around how do you get more power out of the words through the partnerships? How are we more intentful through them? And in the review that's to come, because we'll be 5 years ready, won't we, at the end of it, doing a stock take of what's changed in the 5 years. And the areas that are listed are all laudable. I completely support the particular areas I've been working on. Really good chance to look at it and say, how have they changed over those years? And have we maximised the partnerships to change them? But yes, Chair, thank you very much. Happy to support the paper. Thank you.
Thank you. I do actually have a few points, actually. So do you want to come in first, Margaret? Go on then, I'll let you come in first.
There we are. I didn't press hard enough. Yeah, first of all, great piece of work. Second thought is there's an alignment with the government's 10-year health plan. And I think in some areas that can be made more specific, because I think it's all about your comment about power and linking it to the 10-year health plan, I think will help with that. And then the third thing is, if you have a strategy and you're going to review it, how do you know you're making a difference as you go? And you've talked quite a bit about measures. And I wonder, will it be the role of this board to have regular reviews of progress so that we can see we're going in the right direction, that the things we're putting in place are making a difference, and that we can see the effects? Thank you.
Thank you, Margaret. So my points sort of slightly overlap, so if you don't mind, I'll just bring up my point, Siobhan. Thanks. So I have a few general points, but I have one very specific point because it is part of the recommendations that we accept the principles. So I think my view, and it might be that everybody in the room disagrees with me, but I'm saying it anyway, that's me, is that I do support the principles in general. My issue would be with the section, the bullet point, tackle health inequalities, because it says to address proportionately across the population, which is fine. I mean, that goes right back to Marx in 1875, you know, to those, everything to those according to need, proportionate according to need. So, and I do support proportionate universalism. The only bit I don't like that, and I would ask if we can lose the clause after the comma. And the reason I say that is because, one, it's redundant if you've got proportionate universalism anyway. But secondly, we've had, frankly, this principle, this expression of we're supporting those with the greatest need since at least 2010. And all we've had is increasing inequality. And my strong view, for what it's worth, and I'm sure other people have got strong views in the room, but I'm going to share mine, is that when we say that, what we end up doing, because we've got very limited resources, is only ever addressing the needs of those deemed to have the greatest needs. And you could say, well, what's wrong with that? Well, I feel there's quite a bit wrong with it. In principle, morally, how can you not do that? But what that tends to happen is then we don't address the people who aren't quite in that desperate state. And all that happens is that those people then sink into that category of having the greatest need. And I know we're just talking about words here, so I appreciate people may think I'm being a bit pedantic, but we are being asked to support a set of words. So I think it's not necessary to say that because it's implicit in the sort of proportionalism argument either. But it does suggest that we're supporting an approach which I don't support, frankly, myself anymore. I think it's not going to help because we're constantly then under this emphasis of only helping those with the greatest need. And other people end up being entirely unaddressed altogether. And it's just led to rising inequality. So my proposal would be that we just omit that little bit of that sort of gloss that comes after the comma. Sorry, Siobhan, would you put your thingy on? Thank.
I just wanted to clarify which wording, is it on slide 11? Is that the wording?
No, if you look at your principles on page 2.
Oh, okay. Oh, you're in the paper. Okay. Yeah. Yeah, I agree. It's a similar sentence. I'm just finding it in the report, but yeah, I see what you're looking at now. Yeah. Okay.
Councillor Kerr.
Can I support you on that? Because for a slightly different reason. Because so this is the fourth bullet point under 4.2 in the report, and I think that there are quite a lot of people who are capable of looking after themselves, but might need just a little nudge to achieve it. And if you give them that little nudge, they won't fall into that greatest need category. But if you don't give them the nudge, they might. So if you give a little bit of attention to some people, they can actually then go and help their community in a way they might not otherwise do. And I think that empowering people is something that this it doesn't explicitly say here anywhere, but I think there is definitely a role of empowerment and for communities to be empowered to look after themselves. But the people who can do that are not the people at the bottom, but we need to do something to empower them.
Thank you. Councillor Wright.
Yes, Chair. I agree with you for different reasons. I don't think we should qualify those that are in need or those who are just in need. I agree. There shouldn't be a hierarchy of inequality. You know, and going back to the point I made about the inherent in the Marmot principles, is the need to address structural issues that give rise to health inequality. And I think if we attempt to do that, although it's very much resource driven, then we will capture those who need the actual assistance. And then the point that you made about, well, we focus on a particular group, demographic or whatever, but we still have this systemic situation. Well, the systemic situation will continue to happen whilst we're in a situation of recession, austerity, etc. There, it's the economic drivers that has led to the compounding inequality that we're seeing around us.
Absolutely, Councillor Wright, and there's only so little that we can do about that, so a little bit we can do about that. And I wouldn't have raised this if we were not actually being specifically aggressed to agree the principles now. So I apologise to anybody in the room for which this appears pedantic, and perhaps Andy Appleyard's about to accuse me of that, but this matters to me, and Andy Appleyard, would you like to come in?
Thank you, Chair. It sounds like there's consensus in the room, whether that be for different views or not. From my point of view, it speaks to our prevention activities, which is embedded in our adult social care strategy and numerous other strategies. There is obviously a need to put resources to those that need it the most, but if we don't spend time supporting people very early on their care journey, there is a significant gap that we are missing, and then we'll have more people that are ending up at our front doors needing support. Whilst I'm speaking, if I can just have the opportunity to say, Siobhan, I think lots of people have agreed. It's a really helpful piece of work. In terms of point 3 that you have there, I'm keen to at least engage with you to have some discussions. From an adult social care point of view, the topic that you raised around neighbourhoods and the terminology, that's a really important thing that's happening at the moment, so quite happy to have some discussions with you. Thank you, Chair.
Thank you, Andy. You resisted that opportunity to call me pedantic, so, well, thank you. So, anyway, are people happy that we just take away that clause after the comma, then? Thank you.
Sorry, Chair, I would challenge that, because if we appreciate, saying that you've been applying, the City Council's been applying a universal, proportionate universal approach since 2010, but surely there needs to be some sort of scrutiny on the impact of that work and has it truly been applied? Because if we look out into communities, health inequalities have just been increasing. So clearly the approach just hasn't been worked. That doesn't mean that the strategy itself, it needs to be taken away, if I'm making sense. So, taking it away, I think we run a real risk of not having a focus in certain areas where there is a greater need. So that's my view on that. And because this
was that not that we've had, I think my understanding is that there's a proportionate universalism of the concept that we use right across the health system and in the NHS as well, I think, and in other areas. So it's a well-established thing. My objection was to this phrase, we're going to support those with the greatest need. Because that was the point that I think has been in operation since 2010. And my point was indeed that all we've seen is health inequalities increase in that period. So it doesn't mean that we won't be helping those with the greatest need. I think that if we have this in our principles, though, that's what we'll always revert to, and all that will do is continue this problem. It's a government issue as well. All governments have been doing this. They've been saying this, and it's morally incontestable. How can you not help those with the greatest need? And that's what we want to do. But my point is, if we put emphasis on that, it tends to lead, because we're talking about principles here. If our principle is that that's what we're going to do, that's what, because we have limited resources as councillor, that is what will happen, and we'll get into the cycle, as Andy Appleyard has referred to, as we've seen in adult social care, and no doubt we see it in the health service and everywhere else, where we just see ever greater need. So I'm happy to take a vote on it if you want to push for a vote, Amjad, or you want to put a vote on it. Okay.
Can I just add something, Amjad? So I think the way I think the language has evolved a little bit from that position statement into the presentation, because in the presentation we've talked about support based on level of need, which is that proportionate universalism. So it kind of takes that emphasis, which some may find exclusionary, for that just supporting the greatest need. So I think the emphasis that we've ended up moving to within the slides, because it's kind of, it's language, isn't it? And it's important to tease it out, that support according to level of need is that more of a gradient of support. So it's not saying not supporting those in greatest need, and that emphasis is still there, with implicit in supporting according to need in that proportionate universalism way, if that makes sense. Steve's still a bit anxious about it.
Gosh, I must confess the conversation's gone over my head a little bit, but for good reason. The reason I say that is I think we need to be careful. So a couple of things to pull out. The National Health Service is a universal service free at the point of need. So it does not do proportionate universalism. So that is the National Health Service. The Health and Wellbeing Strategy can determine, if it so wishes, to divert its resource to places of greatest need. And I think that's the question that we have in front of us. I would advise not voting on it. I would advise colleagues with very strong views on specifics of the wording come together and look at it, and we bring it back. I think there's a risk of us arguing about it at the moment without us fully understanding the points being raised. I'd take it away. It feels important. There's disquiet in the room, and I would just take it offline and work through and bring it back through with Siobhan's support. Thank you.
Thanks for that clarification, Chris. I'm probably just talking about my public health colleagues. They're always talking about that, and I think in the end, I think the NHS does quite a good job in some ways at helping people proportionately. But so the problem with what you're proposing, Chris, is that Siobhan has asked us to agree the principles today, and I guess a strategy of action going forward relies on us to have at least agreed the principles. So I'm used to taking votes, but I'm very happy with votes and losing votes if need be. We've got a lot of, I think we're getting a lot of interest in it, and I thought this might elicit a lot. It's good to have a debate. It's good to have a debate.
Just one word. There is a symbiotic relationship between the wording and action, so we need to get the wording correct. But I need to emphasise, I'm not into a hierarchy of inequality. If there's inequality need there, tackle them.
Thank you, Councillor Wright. I think what we're looking at now is, I mean, I think it's probably quite important that we agree the principles today, Chris. So,
sorry, Chair. I just wonder does it need to be decided today? The work underneath the current strategy continues. The review is coming back in November. It's important to get right. It can come back in September. The work under the strategy carries on. So what I'm saying is, does it need, if there's disquiet in the room, can we solve it through the board?
I'm happy to bring Siobhan in, Chris. I mean, personally, I'm used to just making decisions, moving on, let's get things sorted, and then have a basis from which moving forward. And that's how I operate. But I've got loads of people wanting to come in. I'm going to let Siobhan respond.
Thank you. And I suppose this is an evolving piece of work, and all we've done so far is work with a small group of representatives to develop some wording and a position statement of a direction of travel that we want to take for a strategy. The principles, I suppose that the exact wording of I wasn't really expecting the exact wording of the principles to be agreed, if you know what I mean. It was more like, well, this is a general sense of travel, this is where we're wanting to go. If there's more discussion to be had, we can have that discussion either in this space or at the bigger stakeholder event that we have in November. I think it's all in evolution still at the moment, because it is that co-production process of what we want the strategy to look like. So I am happy, I suppose, to amend what we ask of the board to say, to support the sense of direction of this strategy of work and the principles that are emerging and still require further discussion. I wouldn't necessarily be looking to the board to agree the exact wording of those principles, because that might be restrictive.
I'm going to intervene. You have actually put down a set of words, and you are asking us to agree with them, Siobhan. So that is what we had on the table. So I can accept that if you want to see it as more of an evolving thing, but I'm going to then say to the board, then we are not going to accept recommendation. We're not going to agree with recommendation 2, because we can't have a set of words in a public report that is a set of words, and I know that people think I'm being really pedantic now, and then we agree them, and then later on we say, oh, they weren't really what we meant. So either we agree what we mean, or we say what we mean, or we mean what we say. Otherwise, we don't just agree them. And it's fine if you want to defer agreement to the set of principles from today. If you're recommending, I'm going to let Councillor Kerr come in because she's so frustrated.
You judge me well, Chair. I was going to propose an amendment to point 2 to say that we welcome the principles proposed by the working group, subject to further discussions through the process. Because I think we are definitely going in the right direction. I think we need to acknowledge that, but we also need to acknowledge that there is further discussion needed, and that leaves it open for that. So to welcome the principles.
I think we can just leave that. We can say that we welcome it, Lucy, but we're not going to agree them, that's all, because we don't agree. So I think, thank you for that. And that is in fact what we're doing. We're basically saying we largely agree with them. Some of us, and there has been more people speaking in favour of actually not amending those principles. So a majority of people who've spoken want to amend the principles. As one person has said they don't want to, we can look at it again. But we do generally support what it's driving at. Thanks. Thank you, Lucy. We do welcome them, but we're not going to agree that wording. Thank you. So I do have another point, if I may, a couple of other points, because I've read this. And so I think, so again, I know you'll say, so basically this is probably more, I don't know, you probably also want to diverse some of this, but you have brought it here for discussion, Siobhan. So you say, establish better governance for the strategy, as there is no formal oversight and accountability. Have you come up with any thoughts about what that means in terms of governance?
I think that's for discussion later on with everybody. So I suppose what this statement is doing is trying to set the parameters of discussion, that because I feel like as a working group we've taken things as far as we can in terms of that representation, and feeling now that we do need to bring it out and bring everybody back together for a bigger discussion. I mean, I think the governance for the strategy really, it does sit with the Health and Wellbeing Board as the owner of that strategy, and it's just yeah, I think we need to work out, is that, how is that working, and do we all, are there things that we can do differently, or anything to ensure the strategy is delivered and that we see the program, that we understand we talked about measuring the impact and understanding the value of what we do. Did I answer your question?
So you want to bring that up in the workshop, to which all the Health and Wellbeing Board members will be invited?
Yes, yeah.
Thank you. And my final point, people may be pleased to know, is that in terms of some of the... Obviously, I know that you're trying to tackle here the broader determinants of health is what we're supposed to be doing, and I agree with that. But I think what I'm struggling to see at the moment, because our previous, the previous strategy, which was agreed before I was councillor, I think, has specific kind of, invites specific kind of areas of health inequality, or not health, areas of health. and health, where we have health interventions from the council, from public health, from NHS, you name it. What we're looking at, so what I'm getting, and this kind of will lead on very nicely in a kind of Radio 2 link to your next report, is I'm sort of, you've got a list of here for improve the building blocks of health, and these are pretty much the broader determinants of health, which are really important. But I'm sort of not hearing any. What I'm sort of thinking is that, and previously we had a named and specified focus, say on healthy weight and obesity, etc. Here we've got very broad, very general principles that would actually be far harder to measure and monitor actually in terms of outcomes. Very crucial though that is, they are harder to measure. But also, how would this differentiate this board from the proposed resilience board, which is going to be set up, because they will be looking at exactly the same thing. So my point is, and it's a question, it's not a, is are we losing, will we be losing, or will this come later, a specific focus on specific areas of health that, in this?
I think that's a decision to come. So, we've set out the broad direction of travel. We've talked about kind of how we identify what's important for the city, and for example, physical activity is one of those. But then there is a discussion to be had by us all as how we prioritise those, and do we prioritise by programmes of work, or is it prioritising by ways of working, or a combination of those? And I think that's the discussion. I think within the working group, we really wanted to, keep our attention, or include our attention on some of those building blocks of health and the drivers of health, as well as particular behaviours or other things. So
are you seeing there'll be like some potential, because this is a statutory board, and there's a resilience board being set up that's going to address all of these specific factors. So have you given any thought to that, or is that?
Well, I think it's a health and wellbeing strategy for the city, isn't it? Not just for the board. And I think it would be, if the resilience board are kind of going to be thinking about these things, it'd be useful to have that conversation with the resilience board, so we are aligning what we're working on, and the attention that's focused there might be on some things, the attention that's focused here might be on others, or how do we bring those together? I think that's a conversation for how that develops. But it'll be important for them to think, we're doing some of the work here that they will hopefully find really valuable in thinking about what they're doing.
Okay, so I thank you for that. I'll let you come in, Chris. I think that, so it's just something about making sure that we're not there's not a party. This is a metaphor I've been using for some time. We often have a party over here of people coming together and doing things, and then we got somebody who's not in that party setting up something up over here because they think everybody should get together and do things. And there's actually huge amounts of duplication, that's all. But we would need to look at that going forward, Chris.
Yeah, thank you. Hopefully, I'm hoping I haven't got this completely wrong, but this might be the point where you're sort of embarrassed. But I think those specific areas that still exist. So my reading of this, if I'm wrong, Siobhan, is those areas of specific focus. I think there are about 8 areas that are listed in the 21 to 26 strategy. They still exist. Yeah. They're still there. What this paper's doing is a refresh, a rethought, a relook, and the whole thing is going to be coming back in due course. There's going to be the event in October, November. It'll come back because the next 5 years we'll need a new strategy. So I think they're still there. I don't think they're lost. I think the principles that Siobhan's outlining, that we need a resolution on the wording of, just guides where it goes next. And I think I think I'm with you on being anxious around losing some of the specificity that's in there, but I don't think it will be lost. The second thing I was just going to say is, just linking to the previous comment, was the governance has to be very clear. So it's a Health and Wellbeing Board strategy. It has to be owned by this group. That's undeniable. It's Health and Wellbeing Board strategy. It is for the city, but this is where it owns it. The challenge that we've collectively got is there are lots of other partnerships that connect into it. And I think that's a bit of work that needs to be done at the big partnership meeting, is just teasing out, this is the overarching strategy that we all look to, who's doing which bits of delivery though. And I think that needs teasing out. So hopefully that's helpful, Siobhan, and hopefully I've not missed the plot. Thank you. Thanks, Chair.
Right, thank you. Thank you for that. Okay, any further comments on this? Amjad, last comment.
Last one, sorry. Just on the building blocks, and this very much came from the communities, from a point 2 years ago where Alison was involved in a meeting and communities weren't even aware of what a health and wellbeing strategy is, to a point of being sort of central in refreshing the new one. It was, but what communities were feeling was that there was too much of a focus on the health aspects and nothing on the building blocks that actually lead to health inequalities and low life expectancy. So the fact that we've got partners representative at this board, it was important to include the building blocks in it, because that's the only way, even from an accountability perspective, that we're going to be able to get, I'm saying this with respect, get partners to recognise that their sort of how their services or sort of fields play a big part into reducing health inequalities.
Thank you. Yeah, absolutely. And I think that's understood and recognised. I think the problem is that we have, there are other moves afoot, and we won't get onto these neighbourhood health plans, Chris, but there are other moves afoot to do what looks like parallel to what we're doing, so that we need to have discussions in the workshop and going forward with other senior officers in the council, because they're not just, that won't be a council thing either, that will be a partnership board involving other partners who all attend or are supposed to attend this board. So we could end up with my concern. It's not the principle, Amjad. It's duplication. So it's something we'll need to take into account in our discussions. Right. Thank you. Have we finished on that one? Yeah. Yes. Oh, go on then. Very quickly, Cecile. Oh, we haven't. Yes. So yes. Go back to the recommendations. We have definitely noted the report and we welcome the report, thank you. We welcome the principles, but we're not agreeing with them at the moment. And I take it that we all support the next steps. In fact, we've talked a little bit, we've touched on that in terms of what that needs to look at, haven't we, Siobhan, today? Brilliant. Okay, thank you very much. Thank you for everyone on that. Now I'm going to invite Siobhan to talk to us about the place-based partnership.
Thank you. Yeah, you got me just for a minute, and then I'm going to hand over to Karen to do the second half of the talk. So I think this has come here maybe once before or so, that we have had some resource into the city from Sport England, supported by Active Partners Trust, which is Michelle and Karen here, to look at how we understand and then develop a whole system approach to addressing physical activity and health inequalities, but really recognising that any system that produces physical inactivity inequalities also produces inequalities in everything else. And physical activity isn't kind of a unique case, so it's kind of giving us a bit of a frame to look at health inequalities. But some of the issues, we're going back into some of the issues that we've already been talking about today. And that's why we swapped these presentations round, because this felt like a bit of a follow-up. So, and we'll just go on to the next slide. So, the approach that we're making, this, and some of this is quite conceptual in terms of its development still. So Sport England have run a number of pilots across the country on this, and including some work in the city previously, and just really developing on what their work has been. And they've really developed this, and so we often think of Sport England as a sport organisation and physical activity, but what they're really understanding is that, as I've said, none of this happens in isolation, and they're kind of looking at developing this really holistic way of working. So we have been, we put in a bid last year, a bit ago, for a two-phased approach. We're currently in the development phase, which is really understanding what's going on already. So a little bit of situational research and evidence gathering. The data from Sport England kind of highlighted Derby as a really good opportunity to work in this way because we do have those inequalities in physical activity, and we already have a really strong kind of way of system working and partnership working, which we're working towards. And there's a real principle here which reflects kind of where we're going with the health and wellbeing strategy, is that putting residents and communities at the heart, and ensuring people of Derby are involved in shaping and co-designing future opportunities. So what I do want to say is this isn't a separate project. It's not a separate physical activity project or a sport project or something like that that sits over there. What this project is to do, or programme or approach, is to add value to what already happens in Derby. So it gives us a bit of additional resource, a bit of, at the moment, reflection, research, investigation time to really understand what is going on in the city at the moment, what works, where are relationships strong, where might they need some work, what programmes of activity are happening. And all of that knowledge and intelligence will really help us in developing the health and wellbeing strategy in terms of the principles that we've talked about and our ways of working. It will also support our neighbourhoods work, and by neighbourhoods in this context we mean both localities work within the city, run by the council or led by the council, but also how the NHS and PCNs are kind of all moving into that neighbourhood approach as well. Also our Live Well team and Move More teams, it's all kind of integral into that. It supports our DHIP work and other community kind of health promotion work that goes on in the cities, so linking again back to localities and neighbourhoods, and really should help us connect some of that strategic and operational activity. So it's like a bit of glue in the system and a bit of help kind of knitting things together at the moment to think how can we work together better. The initial journey, so as I've said, we've kind of had these conversations. At the moment, we are at point 5, so we're currently working through understanding what working systemically looks like and feels like in Derby City and identifying opportunities for development, working on a place-based approach, so not an organisational approach, but really thinking about a place and the ecosystem within that place. So with community organisations, with services and other providers to better understand what is holding and what's perpetuating those inequalities around physical activity. Making sense of what we've read, heard, experienced, and developing how we understand what's working and what isn't working and why that might be. So all of this, this is intelligence to help us in our strategic frame of mind as to, well, how do we know what works and do we know that we are doing the things that work? So there is some development work going on at the moment, kind of a bit of test and learn process. And looking at developing a theory of change in terms of the future, full award, which we need to apply for towards the end of this year, I think. And the full award is 1.6 million over 2 years. So it's a really significant kind of supportive sum of money into the city to help us integrate and kind of do our stuff better. So I think this is saying similar to what I've said already, but why does it matter? So from walking to work or playing sport, moving more, just in and of itself is vital for our physical and mental health. But not all of us have the same opportunities, and those barriers that exist for physical activity exist for other things as well, so access to food and so on and so on. So by working deeply in neighbourhoods alongside community health and local government in that real local ecosystem approach, we feel that we can provide support to co-design solutions that make it easier to be active for people in a way that's right for them. So it's creating the environment to be active. So I'm going to hand over to this. So Karen's going to talk now about some of the work that's been going on already, so specifically some of the engagement and kind of stakeholder partnership work, as well as some kind of investigating kind of interview work with strategic leaders in the system to understand what is going on in Derby and how we already work and how we can do things better. Over to Karen. Thank you.
Siobhan. So the development phase has brought myself and Lee Timmis into Derby City. It's allowed us to be completely independent from any organisation. So although we're hosted within the City Council, we are part of actually lots of different teams. We sit within the PCNs, we sit with CAD, we sit sometimes in DHIP, we sit in lots of different places, so it's allowed us to be part of everything but part of nothing at the same time, and be that fly on the wall that can just sit back and observe some of the things that do and don't happen in Derby. We meet monthly with a leadership group, and on that diagram at the left, on the right there, that's who's basically on our leadership team at the moment. So that group meets once a month. We sit down for half a day and we look at the work and some of the things that we found out in Derby and where that then leads. What questions does that ask? What doors do we need help with opening? And that's it, that place I can bring those things to that group, and they will then go away and open up some of those doors. So that's what we've been doing since December. In April and June earlier this year, we had an opportunity to do something called a maturity matrix. So this is research that's it's part of the National Evaluation and Learning Partnership. It's a methodology to examine really complex systems and complex place-based systems with a real evidence-led approach. As part of that, there were 8 structured interviews that took place within the city, and they were a variety of, from director level right the way down to people who go out and do things, and community members. And what happens there is, so the next slide just shows that it's Rebecca that's done that. So it's Dr. Rebecca O'Connor that conducted those interviews, and it's an opportunity for those people to be completely anonymised in their feedback. So they get an opportunity to be absolutely honest in their approach to some of the questions. So the 6 areas, so click on the next slide. That's just Rebecca and Rebecca's details. The 6 areas that we really ask the questions around what we want to know, a real deep dive into these 6 areas. So the growing our insight and understanding, supporting and developing people, collaboration within and across organisations and sectors, a focus on learning and adapting, investment, and advocating and influencing for policy and practice. So those 8 individuals had an hour and a half to talk about all of those things in the most honest way that they probably ever had the opportunity of. So that's a real unique part of this, and it's a real unique approach that we've taken in doing this maturity matrix. So the following slides that I'll go through are the insight from those interviews. So within the sort of the area of collaboration within and across the sector, so when I'm speaking about these are some of the things that the 8 individuals have drawn out. So what I would ask is for people to just view them with as much sit back and observe as we possibly can, because I think all of our initial reactions sometimes when we see something that we perhaps don't like is to think, oh no, that's really not me. And we had this opportunity, so I have missed a chunk actually, I'm rushing through. So as part of those 8 interviews, we then had a feedback session. So 53 individuals that work within Derby City came together for a whole morning. Rebecca played back what she'd heard. She spent about an hour talking about, this is what I've heard in Derby. How does that make you feel? Do you think that's something that resonates with you? Do you think that there's something that's been missed? Is there something else that you would like to add? So people had that opportunity to do that. And at that session, we made it very clear, please just sit back and observe as well as be part of that feedback. So some of the things that Rebecca identified, that were identified through the maturity matrix, were that partners were really passionate about the work in Derby and really wanted to work together to better support communities. Another point that she made was she does this up and down the country all of the time, and COVID was never mentioned at any other place up and down the country, but it was classed as a real defining moment in Derby, and that the way in which it brought the city together, lots of different departments and different organisations came together in a really unique way, and that was a real highlight of what people wanted to talk about. But some of the challenges are that the roles and agendas are not always understood, and that sometimes makes it quite difficult for partners to kind of trust each other, and that protectionist behaviours do come out, and that sometimes makes decision making happen in isolation rather than collaboratively. And that there was historical tensions around the cuts that happened to the BCSE. So we knew in COVID there was a lot of money put into the voluntary and community sector from government, and that feels quite difficult that some of that funding's not now there. Some of the developments that were highlighted in those interviews were neighbourhood teams, and when I say neighbourhood teams, that means teams within the council, teams within other departments and organisations that work in a neighbourhood way. We're seeing this really good great progress on that place-based partnership approach, and that PCNs were really working a lot more closely with system partners, really understanding what happened in neighbourhoods and wanting to work together to improve that. And that DHIP was making really positive connections within the community. But one of the key challenges that came out of that is sometimes we portray a system that can be quite smooth on the outside, but when we scratch a little bit deeper, we go, oh, right, okay, there's more here than meets the eye. So there's a little quote there that somebody gave in one of the interviews. So investment, so sometimes there can be a misunderstanding about where money needs to be spent in the city, and there's contrasting views around how that needs to be spent. The transparency, we can't always articulate, or people within different places can't always articulate where the money's being spent. I don't think it's being spent where it needs to. And the legacy, communities feel that you're here today and you're gone tomorrow. But it was viewed that the Sport England investment was a real strong motivator to work together, and that, yes, we have got system challenges that we need to overcome, but actually there was a real strong, this type of work was a real strong motivator to do that. And there's a real desire to work collaboratively, but that only works if we share power. And partners do want that honest, open conversation about funding structures. So growing our insight and understanding that insight's valued is an important part of telling the story of the data, but sometimes there's not a consistency about how we collect that, how we understand it, and how it's then used. So we might collect it in one organisation and another organisation about that exact same community, but actually we're not sharing it all the time. And that somebody said that part of the problem is that there's no strategy and direction for how we're going to fill those gaps. There's a little quote there, I won't read it all out. And sometimes insight and engagement are often confused, and that there's a tendency towards a tick box approach, especially at the end of a piece of work. So sometimes people want to do it, but they don't know how to do it. And as a result of not knowing how, they'll go, we'll leave it a little bit longer, and then it feels rushed at the end. And that where insight is gathered, it doesn't always result in an action. It's because it isn't being collated in a way that's effective and is actually going to influence how we do things. Some areas of Derby are considered to have better connections and an opportunity to gather insight, mainly through the VCSE, than other parts of Derby, and that can feel like there's a lack of openness about what we're learning and a reluctance to share that. Sorry, you can flick onto the next slide. Oh yeah, that's perfect, thank you. And that the insight that we do share tends to have a positive bias. And I think that's us as humans, that we want to share the best parts, not the hardest parts. And that was just to have reference to that. And that it's really difficult to understand when it's complex. And it's a complex city, and we've got lots of different parts and different communities, and that's sometimes really hard to understand. And then if we move on to supporting and developing people, that the place-based work is really supported by leaders, but leadership tends to be held by those with the strongest voices. So when we're in spaces, only leadership is only taken by those with the strongest voices. We sometimes don't always hear the quietest voices that are in that space. And accountability and direction have been questioned. And then again, it talks about that with strong voices, some agendas like physical activity get lost in conversations, and that there can be a perceived power imbalance that's influencing some of the place-based work and how we do it. Although we try to be very impartial, we are sat within a leadership group, and that sometimes can feel difficult for quieter voices within that space. And then a focus on learning and adapting. Learning is valued, but capacity is really limited. We know that we're all running at 100 miles an hour, and we do want to learn, but actually the ability to learn is really limited. We very rarely get the chance to lift our heads above the parapet and go, actually, what am I seeing in its entirety? We're very focused on looking down, but that's the nature of a lot of what we do. And some questioned what learning means, and how people worried about doing the wrong thing. So I might know that there's a better way of doing it, or I think I know that there's a better way of doing it, but actually I'm quite scared to do that, because am I going to be out on a limb if I end up doing it wrong? And when evaluation does happen, there's limited sharing of those findings, and again that there's a real positive bias in anything that we share externally within or outside of our organisations, that we want to be seen as doing well, we want to be seen as achieving well, and that's really difficult to then say to somebody, it hasn't gone well at all, and there's a lot that I need to learn. And then when it comes to advocating and influencing policy, I think this is where, you know, what we've been talking about here today is that there's a real opportunity to influence a lot of things that are coming through at the moment from government, from Derby, for Derby. And that's a real opportunity that we've got, and those policies are going to change the way Derby can live and feel. However, we do recognise that some of that's quite uncertain, and that can feel difficult sometimes. The changes in the ICB, the changes to local government can make people in organisations feel really nervous about what does that mean for me, and what does that mean for my job and my career. But there's a real positive opportunity for something different. So I suppose it comes on to what are the hopes and directions for this work, so that everybody in Derby, councils, organisations and residents are speaking the same language and working towards the same goals. And that really comes in to what Siobhan was saying earlier around that health and wellbeing strategy, and how, as we own that, as a board, how that language can then seep out into other parts of the work that we're doing with the place-based working, and that we support local people with skills and confidence so that they can influence decisions, whether that's decisions in their community, upskilling, like you were saying earlier, Lucy, how can we support individuals that are able to do more, to do the things that they want to do within their communities. So I think you can skip a couple of slides now, sorry, we're just a bit ahead, I didn't realise. And the next. So these are the key takeaways. You know, our need to understand each other to build relationships, to share successes of the work of DHIP and neighbourhoods and PCNs, and really learn from the work that we're doing in those spaces, to think how can we carry on more of that in a great system way that we're doing already, to develop leadership and strategy to empower us collectively to carry out the work that we know needs to happen, to consider how success and failure can be shared and used, to work towards open and transparent conversations around investment, and to build on the positive influence of neighbourhood working. So when I say neighbourhood working, that covers all the different neighbourhoods that we're talking about in all the different strategies and policies. So I think the next steps and the ask of the board, well, our next steps are to build the theory of change that's right and usable and accessible to everyone in Derby. Everybody working in Derby, it's got to be written in a way that somebody could look at it and think, I get what they're doing and why they're doing it that way, and actually I see my role at some point within there, even if it's not explicitly written. That the conditions, that we're supporting the conditions for this to happen through our capacity and bringing in future capacity into Derby, and then submitting a full bid back to Sport England. So the ask from the board would be to note the work, share the maturity matrix findings. We can send that out in its entirety and support where appropriate.
Thank you, Karen. Any quick comments or questions on Karen's report? No, I think you bamboozled us a little bit, Karen, because I have read the paper that came to the thing, so it's so much more expansive, and so I think I would need to see the slides. I don't know if people would be happy in the slides being shared, because there's so much more in the slides. It's not a criticism at all. It's just I would personally need a moment to grasp the range of what you were saying. Thank you. Councillor.
I think you've got it really nicely there, Chair, because I think there's an enormous amount you've told us and some really deep insight. And it's how you then pick that out and avoid losing it when you drop it into the bureaucracy of all organisations. Because I think that's where the danger comes from the I think, very refreshing comments that you've included there. And I think you so easily get bogged down. And I think that the challenge will be to use that different way of looking at our problems, which I think Sport England can bring, to actually, I think you used a phrase like, sort of, I don't know, oiling the wheels or something like that, making the connections. And if we can achieve that, I think that's absolutely great. I think it's a really good vision. We have to wait and see if we can.
Thank you, Councillor Kerr. Yeah, I think you've just given us a lot of information for food for thought as such there. I'm really mindful of time. I think this has been a really extensive piece of work, and I don't want to express it now, but I'm mindful of time. Does anybody want to make another comment on this now? Very quickly then, please, Councillor.
I think it is a really good piece of work, and it highlights the complexity of, working on that granular level when you're in partnership and everybody working with the same kind of approach and with volunteers. There may be, I don't want to be disparaging of volunteers, but they might be really well-meaning, but they might not see the wider implications of what they're doing, and that kind of compromises the effectiveness of the overall work that's being done. But I do think a recognition of that and an understanding of that and how we combat those issues are really important for the whole neighbourhood working approach. And getting hearts and minds together on a project and moving forward on it. And that applies to getting people physically active. And the more people we can get physically active and in a sustained way, the better.
Thank you. So really quickly, Siobhan.
Yeah, I really will be quick. It's kind of a bringing it together a bit statement, but this work has given us some really valuable insight, which we won't lose because we'll be using it within the strategy development work, within the bits of work that are going on in the city. And I think it's important also to note that the next phase of the development plan and the full bid can also provide us resource to think about, well, how do we do things? What is the process? How are we addressing all these really important things that have been surfaced through the work that's been going on so far? So I'm optimistic that it will kind of inform our work.
Thank you. So I'm going to say no if that's all right, Councillor Kerr, because you come in once on this and I'm really mindful of time, but I know you're going to say something important. What I'd suggest then, if it's okay, you're happy to share, I'd suggest, if people are okay with this, that we distribute the slides and then people, if you like, if people wish to, they can look at them in more detail. But for now, we've noted the report. We're asked to recognise the opportunities and commit to shaping its design and delivery. Well, I'd suggest that we need to think about the slides a bit more. So I think we're happy to do that. And I assume, I asked the board if we're happy to support with the partner commitment, the development of a full award and the work needed to achieve this. Is the board happy to accept recommendation 3? Right, well, thank you very much, and thank you for that, and thank you, Siobhan. Right, I'll move quickly on then to the Health Watch Derby annual report, and it's Jim Moore who's going to deal with that. Thank you.
Thank you, Chair. I won't do a full report, a big report, and take up too much time. We have to do an annual report every year by statute, and really it just outlines the work we've been doing over the last 12 months, or for this period between April 24 and March 25. And in that time, we spoke to and engaged with over 10,000 local people. Nearly 7,000 people of those who actually came mainly for signposting, for such things, get advice, information, how to complain about GP services, access NHS services, and how to access dental provision. But nearly 3,500 people came to us about their experience, shared their experience of health and social care, which helped us to raise awareness and provide insight to the ICB, local trusts, to the local authority, and hopefully to make moves to actually improve services moving forward. We published 3 main reports over the year, and about improvements we'd like to see in areas such as using the NHS app, hospital services and CQC ratings of Derby City care homes. The most popular of that was the NHS app report, highlighting people's struggles in using the app and the lack of local awareness. And it also highlighted some inequalities, particularly with the local awareness, in the fact that only 14% of the people asked to, when we broke down, there was about 90% of the people said they'd heard of the NHS app, and about 50% of people said they'd used the NHS app. When we broke that further down, only 14% of the people who said they'd heard of the app were didn't have English as their first language. And it kind of highlights them, because then there was a small uptake of people using that app in the first place. Then within people whose first language isn't English, that was even further. That was even less people knew about the service in the first place. So therefore, they weren't using it. And as this is a cornerstone, one of the cornerstones that the NHS were pushing to help make people engage with their health and improve health moving forward, it seemed there was a bit of a mismatch there. We was able to report that back to the NHS locally through the ICB, and we raised that point, and I think there was it was said that there was going to be some attempt to actually put that right and to make those communications better with those services. We work with local people such as the workshop, people with learning difficulties, and allowed them to actually have a say about the NHS 10-year plan. And we also undertook a forum with the African and Caribbean community to allow them to raise awareness of the consultations of the NHS 10-year plan, and allow their voices to be fed in. And our volunteers, they gave us the equivalent of 250 days' work over the year to support the work. So we kind of cover quite a lot of ground with a very small team. Our budget was £235,000 for the year. And obviously the report is there for everyone to there and watch. So we're just asking people to note the report, really. Thank you.
Thank you, Jim. Do we have any comments or questions for Jim or on Health Watch?
Just to put thanks on record to Jim and colleagues for the work that's been done, and to recognise the challenge that Health Watch is, not just Jim's, are going through at the moment with the changes that were announced. I know that they're being worked through, but thank you.
Thank you. Any other comments? No? I think everybody's absolutely bamboozled by the previous 2 reports, Jim. One brought about debate, the other was just, oh, there's a lot in this. Yeah, so perhaps I'm just speaking for myself, but... Right, well, thank you very much for coming to bring us that report, Jim. I mean, some of your reports, specific reports, such as the NHS Act one, we have had presented to the board before, I remember. I would just have one quick question, actually. Because I'm aware that, as a councillor, I'm aware there's a little bit of a campaign, a round-robin email campaign happening at the moment around Marie Curie's recommendations for end-of-life care, because I'm receiving quite a lot of emails, and so are some of my fellow councillors. And I have met with Marie Curie and talked to them about this, and so it's very topical at the moment. It's always topical, but I know in Derby at the moment it's quite topical to some of the residents. And I suppose I'm just interested that when you tried to do some consultation or liaison or engagement with people on that, you say you didn't get much of a response. Could you? It's interesting to know why.
Yeah, we included the fact, but I think someone mentioned earlier, funny enough, that we don't always report back on what hasn't been successful when we do a piece of work and it gets brushed to one side. But we did try to actually do a piece of work about end-of-life services last year. And one of the barriers for Health Watch, we start from this position that we haven't got names and addresses, and we don't know what services people access up front. So we have to rely on people telling us what their experiences are. And so we found when it came to working with people with end of life, the issues we faced were that, first of all, we're dealing with people who have already had somebody who've gone through the service. When actually talking to the service user, we were talking to people whose parents or loved ones had gone through that experience. And whether it was raw or whether they, for instance, Marie Curie was an outlet for them to actually go and talk to, we realised we were actually being kept outside of that loop. So we didn't have that many people coming forward with a story. What we didn't, to the point, we actually got to a point we actually thought it went on for quite a while and we didn't really have enough to actually say we could actually put a report together. So we could have swept it under the carpet, but we actually put our hands up and said, well, we tried this and we haven't worked, and we learnt some lessons from it, and we haven't wasted, that information has been wasted. There are some, we've been made aware that there are some projects around end of life being undertaken in the near future, and the information we passed into those.
Thank you. Yeah, thank you. I think, well, it's interesting to know, it's quite revealing, isn't it, why some research doesn't work. It's quite as revealing as some research that is working. So that's quite telling. But thank you. Yeah, they do seem to be very active in this area, to their credit, Marie Curie. Thank you very much. So if there are no further comments for Jim, we'll move on to the pharmaceutical needs assessment.
Thank you. I feel like I'm bringing up the rear of the meeting when everybody, I think, is a little tired. So hopefully it won't bamboozle anybody too much, and I'll be fairly brief because I think I've brought a couple of updates previously in relation to the pharmaceutical needs assessment, the last one of which was in May, prior to going out to consultation. We, I think, served everybody on the Health and Wellbeing Board with a copy of the full draft document in June. That's been out to formal consultation for 60 days, and that closed a week or so ago. So apologies for the timing of this meeting. Ideally, would have brought the full and final document that was including of that consultation, but it was a little bit tight in terms of doing that. So you've all obviously had a copy of the full document, and it is quite a significant document, but I'd just summarise in 4.4 of the paper, just a very brief overview of the different chapters and the content that's included. within the pharmaceutical needs assessment. And despite that, you know, it's a really big document, but in summary, it came to the conclusion that the current pharmaceutical provision adequately met kind of the needs within the city. As I say, the public consultation closed a week or so ago. We had a total of 12 responses to that, which sounds incredibly low. And when I looked at what it was last time, actually we had 5 last time. And historically, it's not been a document that's received a huge amount of response to, but perhaps not surprised, it is a very big and a very particular technical sort of document. But just in 4.7, just given an overview of the stakeholders that have responded to the consultation. I've had a very brief look at the feedback, and on the whole, it's kind of pretty positive in terms of response. And from that, there looks to be no significant changes required to the document. There's a few kind of minor tweaks and amendments, but nothing substantial or significant. And in fact, we've got the kind of that chapter in terms of public consultations now been written up and has been included within the document. So we're at the stage of doing those very final amends, making sure that it's as accessible as possible to the population. And the ask of the board is both to know kind of where we've got to in relation to the pharmaceutical needs assessment, and then to receive a copy of the final version of the PNA within the next week or so for review and approval. And once we have approval, then we'll be looking to formally publish the needs assessment by the 1st of October, as is I put 2022 there. I was obviously having a bad day when I was writing that, gone back a few years, but 1st of October 2025, so kind of the beginning of next month, as is the statutory requirement of the Health and Wellbeing Board. I think that's all I wanted to say, Chair. Thank you.
Thank you, Alison, and thank you for your work on this. Do we have any comments? Are we all happy with the way it has progressed, the recommendations? And obviously it is really disappointing that we don't have many responses. And I sometimes think we need I mean, you'll be responding to given requirements on this, aren't they? But sometimes when the situation needs reviewing by those who make the requirements, if, you know, either some other document, some of the questions need to be put, or some other way of consulting with people, or, you know, a different form of consultation or no consultation. But
And actually, Chair, it's probably worth noting that as part of the preparation of the needs assessment, there was kind of surveying and engagement as part of the process of developing the document itself. So the public consultation wasn't the only consultation, it was just on the final document itself.
no, absolutely. I know it's just sometimes, you know, if you have to ask why are we doing these consultative publics, unless there's a different way of doing it. But anyway, thank you very much for that. Moving on to the next one is the update from the Derbyshire Health Protection Board. Alison, thank you.
And apologies, Robin's unable to be here today, and this item is just for information, and as I'm not an expert on this, I'm not going to pretend to be, so we'll just present it as report for information. If there's any questions or queries that anybody has in relation to it, I'm happy to take those away and feedback. Thank you.
Do we have any questions or comments on this particular report? No? Thank you very much. And finalist Alison, with 15 minutes to go, which is remarkable, the forward plan.
Again, Chair, this one is for information. You'll see within Appendix 1, we've got the overview of the items currently scheduled for the next 2 meetings, and then kind of other items that have been put forward and are on the forward plan. So, as always, I think we've got our agenda setting meeting on the 16th of October to fully confirm the agenda, but in the meantime, if there are any items for members to put forward for future meetings, please email myself and Linz, and we'll put them on the forward plan. But yeah, just for information of the board, Chair. Thank you.
Thank you, Alison. So the next meeting is a big focus on children and families, so we look forward to that. If there are no more comments on that, or any of the other items, any other points, I'll say thank you all very much for coming today. It's good to have the discussions, and I look forward to seeing you all next time. Thank you very much.